pleased to have you join us today for our webinar called Health Benefit Plans, Controlling the Chaos, presented by Nurse Deb Alt, the president of Alt International Medical Management. Next slide, please. Before we get started on the webinar, I just want to give a little bit of background on the Validation Institute, who's hosting this webinar today. We do three things at the Validation Institute. We validate, we educate, and we connect. So what do I mean by that? Validate, we help the buyers of healthcare services, employers, and the advisors bringing vendors to employers. We help them understand the fact through the hype. We help them validate the marketing and performance claims being made by healthcare point solutions so that then when they bring them into a corporation, that they are more confident that the solution will do as was suggested. We also educate. The Validation Institute is the home of the Certified Health Value Professional Program, the CHVP, which is the National Health Value Certification Program to help educate buyers and advisor consultants of healthcare benefits. So really, before the CHVP, there was no unbiased way to get an education on buying health benefits. It just didn't exist. Most professionals got their education from the exact same establishment that makes more money when their rates go up and when their services go down. So we saw a real need to fill, and that's part of our mission in the education of our members and audience. And then finally, connect. And connect happens in many different ways. It happens face-to-face in events around the country. It also happens online in our exchange, which we list over 1,600 healthcare point solutions, many of which are validated, many of which are not, but as a tool for the buyer of healthcare to learn about these healthcare point solutions that are making a difference and helping companies and organizations lower their healthcare costs while improving the quality of the healthcare offering. Next slide, please. Okay, great. On the next slide, you're going to just learn a little bit here about the CHVP that I just mentioned. This has 14 modules covering the areas where the employer, the organization, or the advisor bringing healthcare benefits to the organization can learn about how to dramatically lower the healthcare costs while improving quality of care. So this is on our website. We will be also I'm sure the question will be coming in. All the slides from today's webinar will be sent to all the attendees. And we've had over 250 people register for today's webinar. So there's a lot of interest in this upcoming topic. Oh, and I just want to mention too, this last note, for the employers on the call, and we have many, the CHVP courses count towards SHRM recertification. So many of you need to go through that SHRM recertification every year anyway as a human resource professional. And the CHVP was fast-tracked by SHRM and counts towards that SHRM recertification credit. So next slide, please. Great, and so we're going to get started on today's webinar, and I'd like to turn the mic over to Deb Alt. Deb, the stage is yours.
Thanks so much, RD. I'm happy to have the opportunity to meet with all of you today. RD asked me to share a little bit about who I am and my expertise in this particular area. My name is Deb Alt. I'm a registered nurse, affectionately known in the industry as Nurse Deb. I've been a nurse for way more years than my age and young appearance would tell. I started at the bedside in ICU, ER, critical care, and moved into managed care about 25, 26 years ago. Have been working with self-funded employer-sponsored health plans for the vast majority of my career, and have recently launched some programs to help fully insured employer-sponsored health plans as they undertake the endeavor of getting people the care that they need at a price that they can afford. Next slide, please. I am the president and founder of Alt International Medical Management. We are an independent, carve-out, concierge, patient advocacy-based medical management firm. That's a whole lot of buzzwords stuffed into one very expensive sentence to essentially say we are a team of nurses and doctors who come alongside patients telephonically from the point of sickness And we focus on 5 key fundamentals to help that patient and to help their health plan. That is ensuring that the right patient, meaning enough of your members are engaged, are getting the right care, meaning that it is the evidence-based thing that is most likely to cure or resolve or help diagnose their condition, that it's happening at the right time, not too soon, not too late, in the right price. So I'm sure all of you are acutely aware of the disparity between place of service and how place of service impacts both quality and the last right, which is right price. Now, I'm going to tell you a little secret about our industry. If you make sure that the right patient is getting the right care at the right time in the right place, the vast majority of the time, right price is a natural consequence. It's one of those dichotomies of healthcare. The highest quality, best, most effective healthcare in a fee-for-service model, which is what we have here in the US, generally is the lowest price option. Isn't that amazing? So if you get the first 4 right, most of the time, right price will be the natural consequence. There are some exceptions to that, and we're going to dive into those 5 rights much more in depth here in a few minutes. But it's really not as difficult as people want to make it out to be. It's simply hand-holding patients and guiding them using good information. One of the things that we like to point out is that we build our programs to the unique specifications of individual groups. So for example, a manufacturer of 250 employees in a very rural area is different than a manufacturer of 250 employees in a metro area. Their access to services is different, right? It amazes me when we talk to people in remote areas who say, yeah, I travel 2 hours to get medical care, on a semi-consistent basis. And then we talk to people in a metro area who don't want to drive 30 minutes across town, right? So there are different cultural aspects that play into that. And so understanding each individual group is key. One of the challenges for those advisors on the line and for those employers who are participating in this is, what understanding do you have of your population? Do you have a good feel of what the culture in your organization is? Because those are really critical elements as you begin to try and control the chaos that exists within your health plan. And oh, by the way, not only do we guarantee everything that we do, but our company is certified by the Validation Institute for our outcomes. So we're very delighted for the partnership that we have with the Validation Institute and appreciate them keeping our industry honest by validating our advertising and our results. Next slide, please. So I had this very interesting event happen last week. I was sitting down talking with an advisor and a HR department for a new client, and we're talking about beginning to implement their plan. And so tell me if this resonates with you. The first question that I asked was, what kind of employee benefits do you currently offer? Do you have Weight Watchers at work? Do you have smoking cessation? Do you have an EAP? How successful are those programs? Are you getting the right people engaged in utilizing those programs? Now let's take it a layer further. Do you have bundled surgical pricing built into your existing plan design? Or do you have carve-out imaging? Do you have any kind of procedure or service bolted onto your health plan that would be beneficial to a member to utilize, either from a quality of care standpoint or from a cost of care standpoint? So for example, maybe you offer a free second opinion as a part of your health plan. What is the uptake or utilization of those programs? If you're like most employer-sponsored health plans across the country, that uptake is nowhere near where you want the uptake to be. And it certainly isn't anywhere near 100% of the people who could benefit from those programs. The challenge is, I'm always amazed when I say to someone, do you offer an EAP? And they say yes. And I say, how many visits are included in your EAP? I think maybe 3, or did we up that to 6? And how does a member access that EAP? Do they call? Do they go online? If they need to use it, what's the process for accessing it? Oh, well, I don't really remember. I know I've got it in my desk somewhere, right? And so we often see things happening through the major medical health plan that are not, where members are not traveling efficiently and effectively through that plan. Good medical care management is designed to help your people efficiently and effectively navigate the 2 most cumbersome systems on the universe. The health care delivery system, so what care am I going to get, when am I going to get it, where am I going to go to get it, and the health plan system, right? So if you offer free smoking cessation, your medical management, every time they get a pre-cert request for a CT scan because that patient is a smoker, right? Because that's now part of the standard of care, getting CT scans on smokers is very prevalent. Are they reaching out to that member and promoting your free smoking cessation program? If you offer Weight Watchers at work, every time that something is pre-certified through your health plan, and that is for a patient who has an issue with weight loss, are they reaching out to that member and promoting that, right? The key to this is you probably have procedures and services and things available as a part of your existing benefit offering that you promote once a year during open enrollment. You might even go so far as to quarterly put out a flyer, a brochure, a poster, send out emails. But at the point of sickness is when the member needs the information. How do we know when a member is sick? They don't always show up in HR asking, hey, how do I navigate this, right? When they go into their doctor's office and they hand over that unlimited gold corporate credit card, insurance ID card, right? When they hand that over to the provider, we've done a really good job of training providers that if they don't call in and get eligibility and benefits and perform pre-certification, that they're not going to get paid. What you need is incorporated into pre-certification an air traffic controller or a dancing traffic cop, if you prefer that visual, to say, whoa, wait a minute, we don't want that surgery to be done at the local hospital. Clinically, it's safe to do this at an ambulatory surgery center, and we have a bundled surgical pricing arrangement as a part of this plan. Let's divert that care to run through the bundled surgical pricing. Or how about this one? Anybody got caught in this conundrum? Buy and bill drugs through your major medical. Infusions, injections, things that are being administered in a hospital, a clinic, a doctor's office. You might have the best PBM in the world. You might have specialty pharma carve out. You might have the best, most transparent, lowest cost PBM solution. But that's only going to address drugs that are flowing through the PBM side of your health plan. All of those drugs that are flowing through your major medical, who's looking at those and saying, wait a minute, let's back up here. Is it medically necessary? Is it appropriate? What are the billed charges going to be? I will tell you in many, many, many instances, we see the markup on those drugs being as high as 2,000%. So provider buys the drug, they mark it up 2,000%, they send the claim into your insurance company or your third-party administrator. It gets discounted by your PPO discount of 40, 50, even 60%. Gee, thanks. I'm still overspending by 1,000%, right? So making sure that that pre-certification process identifies all of those opportunities to increase the navigation, increase the member moving efficiently and effectively through that plan is going to be key to the success of controlling the chaos that exists in your plan. And let's face it, if you or I, as educated as we are, as intimately familiar with health plans as we are, walked into a doctor's office and got told that our loved one, our child, had a catastrophic diagnosis, the first thing popping into our mind would not be, let me call the nurse at my insurance company, right? So you can go for opt-in on these programs, and doing opt-in is better than doing nothing at all. But the fact of the matter is, when the member most needs to know that information, when they most need their hand held, when it is most critical that they move efficiently and effectively, that the timing of their care is smooth, that they're not getting a giant bill, right? How many Americans skip needed medical care for fear of an unaffordable medical bill? The percentages are staggering. And what are we doing to the people that we serve, the people that we rely on to keep our companies running, the people who are taking care of our customers? How are we helping them to be as healthy as possible, as present as possible, as productive as possible? If we have all of these great programs and we're not identifying the point at which a patient needs them, and we're relying on them to simply opt in, the chances of those programs being as successful as they can be are almost zero. We really have to insert a way of identifying those members, getting them engaged, and trust me, every provider on the planet is going to follow the pre-certification process. The challenge is finding medical management that will incorporate into the pre-certification process all of those unique components that you have bolted onto your health plan to help improve quality of care and decrease cost of care. Next slide, please. So I promised you that we would talk a little bit about the 5 rights of P3CM. And so I'm going to kind of take you through these. The first one is the right patient. In my mind, as a registered nurse and a healthcare professional, which, by the way, little sidebar, or bunny trail as we call them here, make sure when you're vetting your medical management vendors that you understand what the staffing of that vendor looks like. There are many medical management firms out there who use non-medical personnel to have conversations with your patients. You need to make a decision on whether that is ideal for your population or not ideal for your population. I'm a fan personally of having only licensed medical people interacting with patients. Nurses are the #1 most trusted profession on the planet for many, many years running. They also have a license at stake. So they have not only personal risk, but professional risk. If they make a bad decision, if they give bad advice, there's some skin in the game for them. Not so much with unlicensed personnel. So who's the right patient to be involved? Well, in the carrier world, this would be Blue Cross, United, Cigna, Aetna, Humana, the BUCAs as we call the carriers. They typically staff their medical management divisions at 1 nurse per 60,000 employee lives. With that kind of a staffing metric, by the way, remember I said employee lives, that's really 100, 120, 150,000 individual people or members that 1 nurse is responsible for as her caseload, okay? When you staff like that, you can touch about the top 1% of the population. So let me ask you this. The top 1% of the population, are they the ones that are driving your health plan spend, or are their claims getting reimbursed by stop loss? Typically, when we look at a plan, the top 1% of the population blows through the specific pretty quickly, and they're no longer the plan's financial responsibility. So if you have medical management interacting with only the top 1%, whose money are they saving in that scenario? Is it your money as the employer sponsoring the health plan, or is it the stop loss carrier's money? And by the way, if it's the stop loss carrier's money, who do you usually get your stop loss through if you're in a carrier environment? Usually through the carrier, right? So they're really doing that to save themselves money. The other challenge with that staffing metric and with only touching the top 1% of the population is what happens to overall claims cost. So besides being a nurse, I have a master's in business with a minor in math and statistics. How that came to be is a whole long story we'd need a bottle of wine to go through, but suffice it to say that the numbers matter in our situation, and especially to me. I always like to look at what the per employee per year claims cost is running in different models. So in the carrier environment, one nurse per 60,000 employee lives, touching 1% of your population, what happens to your cost year after year after year? It goes up, right? 7, 8, 10, 12, 15%. If you have a flat year, it's a miracle, right? So when you touch so few people, your claims costs continue to rise. Maybe your plan is already self-funded. Maybe you've moved to an independent third-party administrator, but the way that you're getting medical management is by checking the box on the TPA form and letting them decide who's doing the medical management and how the medical management is getting done. A little word of caution about that model. Most TPAs, these would include the carrier-owned TPAs and the independent TPAs, staff at one nurse per 20,000 employee lives. That's better than the carrier model, but it still doesn't let them touch enough of your population. They can typically touch about 5% of your population as they're doing that kind of staffing. And I always ask, what happens to your claims costs in that scenario? Well, you probably don't know. It's hard to get to the bottom of that because guess what? Very few of those organizations publish their outcomes and their data. If you go to enough conferences or if you really hold their feet to the fire, you may get them to make statements like, we've averted trend, or we beat trend by 3%. Or if they're really, really good at what they do, they may say we held claims cost flat. And that's not bad, right? Everybody would love a year or two of reprieve from cost increases. But I would challenge you that even that is not good enough. If you really want to help the members of your population, those valuable employees, you're going to have to do better than that. 80% of your claims are generated by 20% of your population, right? Pareto's law. In order to touch 20% of your population, your medical management firm needs to staff at about one nurse per 5,000 employee lives. Okay, way different metric. So one nurse per 5,000 employee lives can touch about 20% of your population. And guess what happens to your claims cost when you do that? No, it doesn't go up. No, it doesn't stay flat. It goes down. So depending on how broken you are year one, getting good medical management into play will have a significant impact on your cost, right? Year 2, 3, 4, subsequent years, you're looking at a year-over-year cost decrease of about 3.8%. So somewhere between 3 and 4% year over year, your claims cost should be going down if you're touching enough members of your population. So to me, the right patient is any patient who has any health or insurance related problem, question, or concern. It's anybody who's accessing the benefit. It's anybody who might benefit from a higher quality and or lower cost of care, right? So touching enough people is critical. This is also a good point for me to say, your role as the boots on the ground in your local geographic area, within the walls of your shop, your company, interacting daily with the people who are on the health plan is absolutely critical. I like to say that healthcare providers and insurance companies or health plans are like the Middle East. They've been at war with one another for so long that nobody is ever going to be able to solve that. However, many years ago, pharmaceutical companies figured out the one person in this equation who can change things. They started advertising to that person. It is the patient. The challenge in today's model is that there is not a single consumer reports of healthcare that a patient can access to understand what is the right care, what's the best timing, where's the best place, what should I be paying for this. So despite our best efforts as an industry to create wise consumers of health benefits, in many cases by putting a onerous financial burden on the member, thinking that they would become a better purchaser, what we didn't take into consideration was the emotional impact and the lack of access to data. So we can't expect patients to be wise consumers when it's not available to them to get the information they need to make those decisions. The role of medical management is to handhold that patient through that decision-making process. So if you're really smart, you're right now saying, Deb, that all sounds wonderful, but my people are never going to call. Remember that outreach component. And across the nation, employers are making free healthcare for all a reality. The way that they're doing that is saying to their health plan members, if you call in and you talk to the nurse and you go where she tells you to go and you follow her recommendations, we will waive your deductible and copay. And those health plans financially are performing at astronomically better rates than the programs where the providers are doing the pre-certification and the patients are not enticed to engage and get that information. So there are strategies there to get your patients to engage, some of which are extremely appealing in today's environment to get them the information. Right care is the next one of our 5 rights. And I will tell you, I often speak at medical schools with physicians in training, with student nurses, and I always start out those conversations this way. All right, everybody raise your hand when I hit the one that you think is accurate. How many of you think that the practice of medicine is solely an art? And nobody raises their hands. How many of you think that the practice of medicine is solely a science? Nobody raises their hand. So how many of you think that the practice of medicine is both an art and a science? And of course, every hand across the room goes up. I say, okay, first off, why do we call it the practice of medicine? Because if it's me or my loved one, I don't want you practicing on us, right? I want care that I know is going to cure the problem. So calling it the practice of medicine is misleading. Secondarily, while I love all of you, you're completely wrong. The practice of medicine is not an art and a science. It is a science. There are enough double-blind, randomized clinical controlled study trials published on every condition, with some minor exceptions for extremely rare conditions, that we know what works and what does not work in medicine. The challenge is this: there are literally thousands of new medical journal articles published a month. Some studies are indicating that we may cross the mark where there are 1 million new medical journal articles a year being published, right? It is unreasonable to think that any one practitioner, be it a physician, a nurse practitioner, a physician's assistant, a nurse, that anybody as a mere mortal human being can stay on top of every journal that's published. It's difficult even to stay on top of them just within their own subspecialty. Think about it. Doctor wakes up in the morning, grabs a quick shower, heads into the office. They've got patients. They need to see one patient every 6 minutes to make ends meet in their own practice. They have to call the pharmacy back and clarify physician orders or do prior authorizations. They have to review lab results and call patients back to consult on those. They have to make rounds at the hospital, and they still want to make their kid's soccer game this evening. It's not feasible to think that they're going to stay on top of that. These care guidelines, the science, the evidence-based clinical criteria are published. It is difficult to get the hands-on practitioners to be willing to license them because they're not free, right? It's even difficult to get hospitals to license them because guess what? In many circumstances, if you looked at the evidence-based clinical criteria to say, is this MRI the right thing? There's a chance it's going to say no. If we all agree that the studies are pretty accurate, that 30% of healthcare spending is fraud, waste, and abuse, and all of a sudden we insert an evidence-based clinical criteria to direct the path of care to eliminate fraud, waste, and abuse, how does that impact the system that is delivering that care? See the problem with fee-for-service healthcare? While it's the model that we live in, the incentives are misaligned for the providers, right? And so making sure that care is the right care is imperative. And it's not difficult to do if you access the right tools. The other challenge, there is no way for a patient to access those tools on their own. And even if they could, they're all in medical jargon. So it would be difficult for most people to navigate through that decision tree of deciding, is this the right care? Thus, having a nurse handhold a patient through that decision making is crucial. The other thing that I'm sure you're all aware of is most of the time, patients don't even know what questions they should be asking. So even if they're not of a generation that believes questioning your doctor is wrong, right? If they're willing to ask questions, knowing what questions to ask is a challenge. And so arming them with that information. The other thing that I tell patients is there are studies out there that show that even if you don't know what the answer should be, just the fact that you're asking the question changes the care delivery that you will get for the better. Same goes with inpatient care. Patients who have a visitor or an advocate at the bedside throughout that inpatient stay get a different quality of care just by their mere presence. So just asking the questions is crucial. Timing of care is also critical. So I know that you all have this friend in your circle of friends. We all have one. Think about them. They're convinced that their fifth grader is going to go to the NFL, right? Come on. I saw the smile come across your face. The challenge with that is, as soon as that child sprains their ankle, what does that parent want? A referral to sports medicine, a CT scan, right? And my responsibility is to say, danger, danger, Will Robinson. Number one, is CT scan the right care? Because by the way, that CT scan can contain the same amount of radiation as up to 200 plain film x-rays. So danger, danger, there's a lot of radiation in CT scans. And studies show that children's bodies react to that radiation differently. For adults, some studies say as much as 2% of all cancers can be linked back to inappropriate CT scanning. In children, that is even higher. So unless we're sure this is the right care and unless we're sure it's the right time to expose them to that radiation, we might want to rethink that. The challenge is if you do that CT scan too soon and there's too much swelling, the quality of that image is going to be significantly lower than if you do that CT scan at the right time, assuming that they need a CT scan at all. And oh, by the way, where do you want them going for that CT scan? The local hospital at a cost of $2,000 plus, or the higher quality, more convenient, less of a wait time, better parking situation, oh, by the way, only $300 independent imaging facility. As you put those together, is it the right care? Is it the right time? Is it the right place? Right price will fall into a natural progression. There are some exceptions to right price. Anytime it is a buy and bill drug situation, there is a high potential for price gouging. We also see the same thing on durable medical equipment. We also see the same thing on hardware used for joint replacements. So your medical management team needs to be looking out for not just, is it the right care at the right time at the right place, but also, is it the right price? I'm amazed at the number of times that we have, for example, cancer patients or patients with particularly rare diagnoses, which I'm sure all of you are intimately familiar, tend to be extremely costly to health plan sponsors. But the number of times that the exact treatment that that patient needs is available through a clinical trial. Now, here's the challenge. If the physician that the patient is seeing is not one who is administering the clinical trial, he has to refer that patient out to get them involved in the clinical trial. Every patient who walks out the door and does not return is a loss of revenue, okay? So there's no incentive for a doctor to refer a patient into a clinical trial, into a pharmaceutical scholarship program, into a private foundation, or to get a grant to cover that treatment. So it's amazing to me the number of times that health plans spend money on healthcare that they could be getting for free outside of the plan. So let's flip to the next slide, because I'm sure all of you are anxious to hear, when you do this, what kind of results do you get? And so I'm going to give you a couple of examples. The first being this picture of a sneaker, right? We had an actual case not too long ago where a patient, prior to their plan switching to the current plan, had surgery to correct a bunion on her right foot. She went to the surgeon, she had the procedure done. When she went back for her post-op visit, in her words, she was very surprised by the appearance of her wound. The doctor said to her, "This looks really good. You should see a bad one," as she describes it. She went on through the healing process. She had a massive amount of scarring as a result of that first surgical intervention. So severely, in fact, that often the scar itself would be rubbed raw, despite her doing modified shoe wear. Her plan changed and put in this type of medical management approach. She called in to pre-certify having the same surgery done on the left foot. When she did, we said, how did you pick this surgeon? And we guided her to a higher quality surgeon. Now, be aware, because there are probably a couple of hundred different quote unquote quality or cost transparency tools on the market. I recently read a review where a patient gave a world-renowned surgeon a 1-star rating. And when you read the review, the patient said, "I gave this physician 1 star because the wallpaper in his waiting room looks like it's from the 70s. This is a guy who created the surgical technique that this patient was having done. Make sure whatever quality and cost transparency tools are being relied upon are measuring objective quality data. I often tell people, especially for neuro and cardiac surgery, seems like these people don't always have the best bedside manner, right? But we're not going to him because he's a Casanova. We're going to him because he's a top-notch cardiac neurosurgeon, right? So danger, danger. Patient reports of happiness are not always good ways to measure whether a doctor is high quality or not. But back to my foot story. So for the left foot, she had the surgery done by a much higher ranked physician. The outcome was astronomically different. Her recovery was much faster. The amount of scarring that she had was minimal. As she puts it, when she went back for her follow-up appointment, she instantly knew that this was a different recovery, because when they unwrapped her foot, the edges of the wound were very closely aligned and the swelling was much less. So she had a much better outcome. In fact, the second surgeon actually went back and did a revision on her scar on the other foot. Quality of care matters. All right, our next case story is a vacuum cleaner. Not because we're planning on any of your people vacuuming their home, but because I figured you wouldn't know what a wound vac was if I put a picture of that up here. This is an interesting story because a patient had a skin cancer removed. And in doing so, it was such a large area that they were not able to close the edges of the wound. Unfortunately, they did not have pathology present during that initial surgical intervention to ensure that they got not only the cancerous cells, but what we call a clear margin of clean or good cells all the way around that cancer site. Because they could not sew the wound together, they decided that they were going to use a wound vac. When we got the pre-certification request for the wound vac, we said we need the pathology report showing clear margins that they got all the cancer, that there are no cancer cells left. They could not provide that. So we denied the wound vac. Much to our chagrin, they went ahead and did the wound vac anyway without prior authorization. The patient did not have clear margins. Part of a wound vac is a pressure changing device. That patient subsequently not only had problems with the healing of the wound, but those cancer cells mobilized, and the patient had a much more serious cancer than what they originally started out with. The evidence-based clinical criteria ask for certain things to make sure that what is going on is the right care. It is imperative. There are risks associated with every medical procedure. And in many instances, things can be made drastically worse instead of better when that criteria is not adhered to. All right, on to our next case study. This one is about a buy and bill drug. And I will admittedly say this is the worst case scenario I have ever seen. And so I just want to let you all know that part of medical management is tenacity and perseverance. I call it the pit bull effect. So this is on a patient who's a dependent under a health plan of a manufacturer in a rural Midwestern town. This is the one manufacturer that is left in that town. They are the third largest employer in that geographic region, right behind the city and the school system. They don't even have a hospital in their town anymore because the hospital closed up, right? Many of you are probably in that exact same scenario. This poor child has Down syndrome to start with, and as many Down syndrome patients do, developed cancer in conjunction with their Down syndrome. The medication that they decided to use to treat that cancer was an appropriate medication. It was not available through any clinical trials or community resources. And so as a part of our pre-certification process, we asked for the anticipated bill charges of the drug. In this case, they were going to bill $117,000 per dose for the medication. Now, we use a resource called Micromedics to look up the wholesale acquisition cost of drugs. It's essentially the Kelly Blue Book, but for drugs. Used to be called the Red Book, by the way. And so we look up the drug, and it's available through 3 manufacturers, one for $1,000, one for $6,000, and one for $16,000. So me, being the smarty pants that I am, figured, somebody just fat fingered the charge master. They meant to put in $17,000 when they're paying $16,000, and then it goes through the PPO and you get 20 or 30% off and the cost is reasonable. By the way, if they buy the drug in bulk, they're probably getting it for lower than wholesale acquisition costs, right? So keep that in mind. So we call the hospital, I'm having conversations with them. I can't get them to recognize that they're overcharging for this. So finally, I work my way up. I'm calling the CFO at the hospital. I'm very friendly and polite. Hey, I think I might have found an error in your charge master. I'm guessing somebody just hit the one twice, that you meant 17,000, not 117,000. And I've got this request coming through and I can't get this authorization finished and I really want to get it finished up, and could you call me back? So after multiple phone calls, the CFO finally responds and says, nope, that's exactly what we charge for that medication. Now, when you get into that situation, there are strategies around that, okay? You can negotiate a single case agreement. Most providers who are participating in your PPO network, if you're using a PPO network, will not agree to that. Danger, danger. Don't think that going RBR or RBP or RVI is going to change that. If the RBRVS or the Medicare allowable of that drug is $16,000 and their intention is to bill $117,000 and you only pay them $16,000, do you think there's going to be a lot of noise? Oh, heck yeah, there is, right? So you need to be identifying that. Even if you've done RBP, you need to be identifying that up front. The long story short of it is that we did end up paying only $17,000 a dose for that medication, but only after many, many back and forth conversations with the CFO of the hospital, to the point of saying, well, you can bill $117,000, but you're not going to get paid $117,000. We're going to pay you a fair and reasonable cost for this. And when we don't pay you what you want, we hope that you will sue us and put this case into the public domain. And then we will have a world-renowned PR firm having the media present so that we can show exactly what you're trying to do to this poor patient. And oh, by the way, if this manufacturer goes bankrupt, imagine what it's going to do to this community. So sometimes you have to employ the pit bull effect to get to where you need to be. Needless to say, they agreed to a fair and reasonable price rather than facing the media. All right, one last quick case story, and then we're going to show you the PEPY and open this up for some questions. Many of you are aware of coronavirus, right, and the test kits, etc. However, you need to be aware that the real way to diagnose coronavirus is through a CT scan. It is imperative that your members understand the highest quality and the most cost-effective venue for getting those CT scans done if there's an outbreak in your community. And hint, hint, it is not the local hospital. So if you don't have a plan in place for that and you're in an impacted area, this is a great time to capitalize on the massive media hype that's happening around that particular condition to say, don't spend thousands of dollars to go to the hospital for a CT scan when you can go to an independent imaging facility and get a CT scan at a much higher quality, lower cost venue. All right, next slide, please. This is the PEPY that the Validation Institute reviewed for us. If you'll go back one slide, please. That shows you, depending on what level of aggressiveness you want to apply to your medical management, what volume of patients you want engaged with your health plan, and how intensively you want to go after those opportunities to get rid of fraud, waste, and abuse, to steer to the highest quality and most cost-effective places, to ensure cost control on buy and bill medications and equipment and supplies, where you can expect your plan to perform. So in 2018, the national average PEPY, meaning per employee per year, which is your claims cost, medical and prescription claims combined, allowed amount. Always look at allowed, not paid, right? Because you want to know both what you paid and what your members paid. Ran at around 16,900. If a group comes to me and says, I would like my PEPY to be, and the number is higher than 2,000, there are strategies to get you there. They are not always zero noise strategies. As a matter of fact, I'm not aware of any zero noise strategy. They are going to require some boots on the ground effort from you. The lower you want your PEPY, the more effort is required by those that are in charge of the health plan. No vendor can do this for you. Even as wonderful as my company is, there are members that we want to engage that we cannot get on the phone, that will not respond even when we send them a letter. We need somebody at the work site to go down and find that person and say, hey, I don't know why the nurse is trying to reach you, but she is, and they're really great. And how about I dial my cell phone and hand it over so you can talk to them, right? If you want to get your PEPY under control, you're going to help the right patients get to the right care at the right time, in the right place, for the right price. So thank you so much for listening to me drone on and on. We've got a few minutes left, and I think RD may have some questions already that people have been submitting in. Been seeing the little button light up here. So
Yeah,
RD, fire away.
I sure do. The first question that's come in is, the question is, does this work with all types of healthcare plans? For example, fully or self-insured, PPO or RBI?
Yes, the difference is how well it works in terms of cost control. I'm a firm believer that every patient in America could benefit from having a nurse walk them through those basic 5 rights. If you're in a fully insured plan, it's not going to lower your premium, but it will impact your loss ratio, which should in turn impact your premium, right? So the question is, define impact and define work. If you're talking about being an added benefit to handhold your members to help them, the answer is a most resounding yes. If you're talking about cutting the cost of healthcare, that's going to vary depending on the funding structure. So whether you're fully insured, level funded, if you're in a captive arrangement, if you're fully self-funded, that kind of thing, that will be what impacts how much of a transition out of SG&A into your gross receipts will happen.
Excellent. This is from a manufacturing employer in Wisconsin. Do all TPAs and carriers let you carve out the medical management piece?
Unfortunately, no. In fact, most carriers will not let you carve it out at all. If you really get into it and study it, you will find that carriers have arrangements with providers. And it makes sense. Think about it. The last time that you purchased health insurance, you probably asked your broker or consultant to do what's called a geo match. Because let's all face it, if the CFO's wife's OBGYN is not in the plan, that is not going to go well for us, right? The problem with doing a geo match is what you have just done is incentivize your carrier to make every provider on the planet happy. So those doctors that graduated with a 4.0 and those that graduated with a 2.1 are all in the network, right? Their agreements often say things like, we won't scrutinize length of stay until it exceeds national average. Well, national average length of stay is about 2.5 times longer than the goal or ideal length of stay. Those contracts say things like, we will not do steerage, right? So have you ever done this? Have you ever gone to your insurance's website and said, show me a cardiologist in Columbus, Ohio? And it gives you a list and you print it out and you lose the list, but you remember that Dr. So-and-so and so-and-so and so-and-so were on it, you think. And then a couple days later, you go back and you do the same search and it gives you a whole different list of doctors. It's because they have their system set up to rotate down through all of the doctors so that all of the doctors get the same number of hits, right? There's no impetus there to look at quality of care when they're making physician referrals or helping people find doctors. And their contracts with those providers often prohibit them from being able to do that. Now, getting them to admit that in public, Many of you hopefully are familiar with Dr. Bricker on LinkedIn. He's got some videos that go into that phenomenon and cites his sources of where he's had carrier executives sharing that information with him. But there's a lot of interesting stuff that happens in that carrier world. Some TPAs are much more likely than carriers to allow you to carve out medical management unless they have made the investment of putting a medical management unit in-house. And typically when they do that, they're at that 1 per 20,000 employee lives ratio. So it doesn't necessarily get you where you need to be. It's better than going straight carrier, in my humble opinion, just because you're going to have more people impacted. But independent medical management is going to get you the highest return, the highest engagement. By the way, they all cost about the same. Isn't that something? So what you're paying, if you pull your contract for your health plan with your carrier, and if you can get them to line item it out, you will find that what you're paying for medical management in a carrier environment is extremely similar to what you pay in a TPA environment, is extremely similar to what you pay in an independent environment.
Very interesting. We got another question from an employer in Texas. I thought we had medical management because we selected it, but we're not doing well on our PEPY. Are you saying we don't have it?
You probably have some form of medical management. Whether you have utilization review or utilization management, even though they sound a lot alike, they're very different models. So I would look at that to start, because that's what's going to have an impact on the inpatient bucket of medical spend. The Milliman Medical Index breaks your claims cost, or your PEPY, into 4 buckets: inpatient, prescription, outpatient, and physician. And I put them in that order because that's biggest to smallest. So your inpatient bucket is your biggest, and your utilization management or your utilization review is what has an impact on that. So that's kind of the low-hanging fruit. Utilization review usually looks at diagnosis code and gives length of stay based on that. So for example, a total knee replacement, if you're looking only at the code and the length of stay table, you're going to give them 2 days of inpatient hospital stay for that. A lot of total knee replacements, by the way, can be done at an ambulatory surgery center nowadays through a bundled surgical pricing arrangement. So if you're spending more than about $12,000 on a total knee, you're spending way too much, okay? So utilization management versus utilization review would be a place I would look. The other place that I would look is whether your plan does care management or case management. They sound a lot alike, but they're very, very different. One is focused on identifying an individual and managing that case or that episode. And it's more of a reflective, right? Looking back at what has happened and being a paid historian, as I kind of affectionately refer to it, versus care management, which means I'm working with that patient to drive them down a particular clinical pathway or a care path. So very different, even though terminology sounds the same. And the other problem, and you will see this across our industry, is we do a very, very good job of bastardizing terms, right? So people will call it utilization management when what they're really doing is utilization review. A good consultant or advisor will know what the admits per thousand, average length of stay, average cost per day should be for your inpatient bucket, right? So getting beyond that kind of adoption of terms. The other thing that I hear a lot of people talking about is, well, my carrier says they do RBP, for example. And we kind of chuckle and go, yep, they've implemented it at the brochure level. In other words, it shows up in the brochure, but when you actually get down to how they're doing it operationally, they're not really doing what they're saying they do in the brochure, which is why things like the Validation Institute are so super critical. You've got to have somebody getting under the covers and looking at the wrinkles and warts and making sure that those claims are valid and that the math actually works and that their allegations and their claims really hold water.
Oh, thanks. We have time for just one more. We have lots of questions that we will send over, Deb, and then we can send it out to all the customers. We're getting the continual question of, will the slides be sent out? Yes, we'll be sending a recording of the entire event as well as answers to the questions that we can't get to. But let's get one more in. When you talk about quality of care providers, how do you know who's quality provider?
Oh my goodness. I keep telling my pastor every Sunday, if God loves me as much as you say he does, and I'm sure he does, then at some point in the very, very near future, we will have a single Consumer Reports of Healthcare. Right now, my nurses access on a daily basis 28 different quality and cost transparency tools. And as I alluded to earlier, there are hundreds of them on the market. Every day, we vet different quality and cost transparency tools that are coming onto the market. So we have an affinity for those that are purely objective data and that are case mix adjusted, right? So we don't ever want a provider to say, of course my mortality rate is higher. I only treat the sickest of the sick. With the background of math and statistics, there are ways to statistically adjust those. But here's the challenge. If you have a patient who is going inpatient in Portland, Oregon, you may very well have to use a different quality and cost transparency tool than if they're going inpatient in Orlando, Florida, or Baltimore, Maryland. So there is no single quality and cost transparency tool that relies on objective, validated, mathematically and statistically correct data. There's just not a single tool. I sure wish that there was. It'd make us much more efficient internally, and it would make it much easier to get that information into the hands of a patient. Those tools exist, but there's not a single tool.
Great, great. And I just want to remind the audience that to find out about very high quality and validated partners such as AIM, go to the Validation Institute website, validationinstitute.com, and click on validated programs, and you'll find these companies and where the math has been checked out. So it's not just them making the performance claim, but it's actually been validated by an independent third party. I would like to thank AIM very much for today's webinar, Deb, and thank you for all this great information you've provided to the audience, and to everybody who's asked questions that we couldn't get to. I'm sorry, but we will get those answers out and circulate those actually to everyone. So, and we maybe end on the last slide there, last slide, and any last words, Deb, that you'd like to say?
Just thank you so much for everyone participating today. I look forward to your questions. Certainly, if there's anything that we can do to assist you, I know that both RD and the Validation Institute, myself at AIM, would be happy to help you in any way that we can. Look forward to us all working collaboratively together to fix this broken mess that we call healthcare in America today.
Amen. All right. Thank you, everybody, for listening today, and thank you, Deb, for the great information. Have a good day, everyone.